to welcome Alex, who now you all know now. Alex is the director of the Manitoba Primary Care Research Network, and he'll be presenting today on social determinants of health and behavioural risk factors in primary care EMR systems. So over to you, Alex.
Okay, can you see it in correct presentation mode?
Like no, we see your speaker notes. There's no notes.
Okay, I should have pulled this off my, hold on one second. If not, I'm just going to pull this off my, let's try this. How's that? Better?
We see the slides, not in presentation mode yet.
Okay, screw this. Hold on one second. There we go. Okay. I can never get it to work properly. Oh, now I just lost my mouse because I pulled it off the screen. Hold on. Okay. That should be good, right?
Perfect.
Okay. I was going to try to do it with my notes, but I'll endeavor to stay on time, and then you can ask me really hard questions like I enjoy asking other people. Okay. So I'm going to talk to you about addressing risk factors in primary care settings, and I'm going to give it to you from the clinician's eye view in some cases, but as Linda mentioned in the introduction, I'm a clinician researcher, clinician scientist. I direct some research and do some work in practice-based research networks, and I lead the network in Manitoba. Worth mentioning that I'm joining you here from my basement, which is actually on Treaty 1 territory, which is the original lands of the Anishinaabe, Cree, and Oji-Cree, and Dakota and Dene peoples, and also the homeland of the Métis Nation. And I should say I'm quite grateful. My water's over here to be drinking the water from Shoal Lake 40, which is just east of us here in Treaty 1. And I think it's worth all of us sort of taking a minute to reflect, how we got to this wonderful land and the treaties and the agreements and some of the non-agreements for some of you in unceded territory of how we got to this wonderful place, and some of the luck of history and geography of how we got to where we are. I have some conflicts. None of them, I'm not going to talk to you about any of these things in the talk today. So suffice to say, I have some research grants. These are the three things I'm going to try to cover in the time we have together. Talk to you a little bit about the clinical importance of sort of why social determinants and health and behavioral risk factors are so important. And I think you got some of that overview in the previous talks about, this is important to people's health, and so we should collect it and measure it. And I agree with that as a baseline premise. I'm going to talk to you briefly about practice-based research and learning networks and how some of those operate in terms of extracting and processing these kind of data. And then also to talk a little bit about the current and future state, at least from the clinical lens, of how we use some of this data. I would say clinical and clinical research lens of what we have and what we use and what's sort of typical, and some of the work that, some of the presenters and you guys maybe in the future will work on is upgrading this to something that's a bit better. So we know that risk factors exist for many acute and chronic illnesses, and many of them are actually social or environmental, and sort of constructed around, the environment that we live in. And when I say environment, I don't just mean, physical environment, but also the sort of, the environment of the society and those kind of things. Many of these inequities were quite exacerbated during the pandemic, and many people for the first time sort of understood, and it was in the news that, there were different rates of COVID in different communities based on different factors, and many racialized people suffered, greater rates and worse outcomes for various reasons. And so that was an important sort of lesson learned from the pandemic. Many people who've been working in this area knew that was true long before, but the pandemic kind of, I like to say, I think it's a bit of a truism at this stage, that it affected frail people and frail communities the greatest. So those that were the highest risk were those that didn't have some of the luxuries and the privileges that many others had. And so that became quite obvious in the pandemic. And of course, I think, as someone who does practice-based research, that these are vehicles to help us understand some of these underlying risk factors and see what they are in the real world. So we know that medicine is not the most important driver, and I say that as a physician. So, I can be the best doctor in the world, but I only take a small chunk out of the fact that median life expectancy for both men and women are very much a determinant of where you live. That's a map of Winnipeg. If you don't know it, you can see the inner core of the city has the lowest life expectancy, and as you fan out into the suburbs, it gets greener or older and older. This heat map is repeated in many cities. I think, I don't know, I can't say all cities, but I would say most cities have this. I'm sure if you're in Vancouver, Victoria, there's a very similar map that looks like downtown core. In some cities, like in Toronto, you see that you actually don't see it in the downtown core as much. There's a bit of a ring around the city where there's higher mortality, and it's dramatic, right? It's like 10 years different. And the first city to do this, I think, was London, England, not Ontario. And so this milieu of what makes us sick or what leads to disease is many things. It includes sort of, things like income and gender and social exclusion and a whole bunch of race, ethnicity, and other factors, right? There's a long list of things that go to contribute. Some of it has to do with your access to healthcare and your sort of underlying genetics, and then a little bit, and then the environment, but potentially increasingly so. So this slide is quite old, and many environmental factors are probably going to, as we wreck the climate, probably going to actually increase in what actually leads to more morbidity and mortality. And so, healthcare only contributes a small amount. Another way of thinking about that is the social, cultural, economic, environmental milieu that makes up your individual risk factors. And so these things are, some of them are under our control, some of them are not, right? Where you happen or have been lucky enough to be born has a huge impact of, how long you're going to live and the diseases you're going to obtain. And so, related to my previous difficult questions, we know that if you don't measure something, you can't manage it. But at the same time, that measurement can be very, very difficult. And my favorite Don Berwick quote is that some is not a number and soon is not a time. And I had this up in my office for a while, and there was a Post-it note because there was a health administrator person that actually said that at a meeting, and I repeated it. Someone said, well, I hope we'll get this thing done. And I said, well, hope is not a plan. So that's my addition to the Don Berwick quote. Now, this is probably not news to you folks in doing an informatics master's, but this is a truism in sort of computer science, right? Garbage in, garbage out. And garbage out also relates to bias, right? There are a number of areas, especially in this world of AI. This is one of the early examples where sort of an AI type tool or fancy algorithm really was biased based on the shitty data or the biased data that it was fed. And so what this particular algorithm, if you're familiar with this case, I won't go too deeply, but it's worth looking up. And so what it showed this was from an American health system, and they actually showed that the African American patients had less need for critical care. And it was this whole basic thing because they were more likely to not have insurance, and so then be kicked out of the hospital. And so they were actually getting less care. So it said, well, they don't really need as much care. And so we can drop the amount of care that they'll be covered for. And in fact, it was all based on the fact that it was just a surrogate. Their racial background was a surrogate for not having adequate healthcare. And so the costs piece was all messed up. And so you have to be very careful when we apply these algorithms based on historical data. This is one of the challenges of AI in general. If we're training AI based on sort of all the corpus of the internet, well, there's a lot of incorrect, biased, terrible things that are on the internet, and it doesn't make them true just because they happen to be in a book or an article or something. So we need human heuristics at times. And of course, the godfather of health informatics, Larry Weed, said if we accept the limits of discipline and form as we keep data in the medical record, the physician staff will be better defined. So he was a big proponent of ensuring that the record include the nuance of the data and was structured correctly. He's also famous for saying coding is caring. And so, one of our jobs as clinicians and potentially you folks as informatics professionals is going to be, how do we reflect the note and this increasing, or the chart in this increasing complexity. So one of the ways I think we can do this from the research and the quality improvement lens is to use networks of groups. I lead something called MAPCRN, the Manitoba Primary Care Research Network. It's part of a larger Canadian network called CIPSIN, and there's an Ontario version where they've grouped them all together and they link the data with administrative data. We in Manitoba also link with administrative data. And so these learning networks, in my mind, are a vehicle to help us achieve a better understanding of this nuanced clinical record. And they fit somewhere in this idea of the learning health system, where having data allows us collectively, when we network these things together, to make better decisions in terms of new programs, designing new programs, implementing new programs, and that cycle that goes beyond just a small quality improvement project, but actually considers the whole health system as a learning system. And we've done some work on this in Canada about trying to use the data to understand complex conditions like frailty, which is really a composite of many things. And this idea that the College of Family Physicians puts out around the patient's medical neighborhood, starts with the patient medical home, that this layering of services and access, and the challenge going forward is going to be to actually bring our data systems up to a sort of almost a 20th century standard at this stage, but maybe eventually we get to a 21st century standard, right? Because most of the information that flows currently through this patient medical neighborhood, it really doesn't use modern techniques. Where the healthcare is the only industry that remains, that still uses, in large part, technologies that were invented in the 1800s, like the fax machine. And so we really have a long way to go in many cases to get to this interoperable record. And one way of patching it together is the concept of having learning networks that actually do some of the patching together. And I'll explain to you some of this in just a bit. So PBRLNs, PBRN is the old term, we're including the L for learning. We can do things like measure behavioral risk factors and sometimes use surrogate outcomes and contribute to the sort of learning health system. And so this is some work that I've participated in, looking at, if we think about behavioral risk factors. So this is not exactly social determinants, but it gives you a flavor of some of the nuance here. And so looking at risk factors from the perspective of, well, things that people do, whether they smoke or drink or use substances, helps us understand their risk of disease. So in the case of alcohol consumption, it contributes to about 7.7% of deaths. That's data from 2005. It has a lot of downstream effects, and there was just a recent guideline, and probably hit the news if you were listening, that the safe drinking amounts have dropped. Basically, if you think about it from a medical perspective, anywhere where the alcohol touches potentially can harm you, and so you should try to limit your consumption. But I don't know if you can see in the camera, there's a wine rack behind me, so I don't always practice what I preach. So now, but who gets asked about their alcohol use? So about 40% of patients had their alcohol use documented in a study that we helped. So we patch the records together in these practice-based research networks. And then we do some processing, and I'll explain a little bit about how that works. And so we found that 40% of patients actually had their alcohol use documented. And then it was more common in certain groups. So males had their alcohol use documented a bit more commonly. Older folks, makes a bit of sense because it's just more time for the data to accrue. And people who saw their doctor, their primary care provider, PCP, more often, and at that threshold of 3 or more visits. So, and people who had some comorbid conditions. So sometimes maybe the primary care provider was screening based on things like hypertension or depression, and those with heavier consumption had a higher rate of having it documented, which again makes sense, because if it's a problem, you're more likely to put it in the chart. A lot of the 60% where it wasn't documented, maybe some of those people didn't drink, so people didn't bother to put it in the record. But the EMR data, I think one of our previous speakers cringed when he heard the word free text. Well, most data that goes around alcohol in primary care EMRs in Canada is free text or some version of a dropdown that someone has created that's more or less free text. So when you try to compile it or aggregate it, it's basically free text. And so here's just a few of my favorite examples with spelling mistakes and all sorts of funky things. There's also, I have a 10-year-old son, and there's still a 10-year-old boy sort of still locked inside of me. And so I always giggle when I hear the term hepatitis. I just can't help myself. It's just too hilarious. But that was a real record. And you can see in this free text all sorts of gobbledygook, which as a clinician, and maybe some of you can sort of understand. But computers often have a very hard time understanding what 2 beers per day and more on the weekend means. But so you can see how this is challenging. In the world of medication cleaning, so the CIPSIN, or the Practice-Based Research Network that I'm part of, we do a whole bunch of data cleaning. And for things like medications, it's actually quite straightforward, right? You get some text in the EMR, you clean that text to bring down to sort of the decipherable amount, and then you can connect it to a code, right? And so ATC codes and ICD-9 codes for diagnoses. And so we have algorithms that do this kind of thing. But in the case of things like alcohol, smoking, things that get entered in free text, we need these natural language processing models. And so this is just an example of one model, and I won't go into the details because this slide was done by a computer scientist, and I frankly don't entirely understand it. Because I just sit and watch and smile and then wait for the computer science folks to do the cool math. But we extract the data, we develop a reference standard. So that's actually where we have someone read those gobbledygook texts and say in sort of plain language what that means, so that someone can build an algorithm that actually ties those things together. And sometimes that algorithm gets really good at reading the natural language, and sometimes it still spits out, well, we don't know what this is. Sometimes we can figure it out, sometimes we don't. So then, but that's the sort of applying that reference standard. And then the training and the validation happens over and over and over again. So machine learning is not really machine learning at all. It's actually machine teaching. You're going to teach the machine how to work properly. And maybe with all the AI and stuff, maybe ChatGPT will get better at this. But at the current state, for most health research, we're using these kind of validation algorithms. This is a particular model we used for this alcohol study, which was the bag of words model. But there are a bunch more, and this field has advanced quite a bit since the time I did this study. And so what we were able to do in this study was actually break down the text to be able to identify who were the non-drinkers, who were the light, moderate, heavy, the past drinkers. And so we were able to sort of aggregate these records and be able to pull some meaning out of all of that free text. We're doing some work now about substance use disorders, and it's not quite finished, but we were using an older data set. This study, as you can imagine, got a little bit sidetracked and screwed up because of the pandemic. But it's the same general approach. We have medical students that review the documentation, they do the categorization, and this one's still in process. So taking the records that we have from the Manitoba network and breaking them down and being able to sort of delineate the types of substance use. The current state is really aspirational in some cases. We use the data one patient at a time. I'm going to give you an example of another study that took this quite a bit further. And then the other thing that we commonly do, it was alluded to in one of the past talks, is we use postal codes to derive social determinants of health from census data that's collected from StatsCan. And I'll show you some examples of where that's been shown some interesting findings. And then, this aspirational integration, which some of the other speakers spoke about, and I won't get too far in. So this is a cool study that basically did what I'm doing in a study, but they published it first. So I'll tell you a little bit about what these folks did in terms of the automated detection and how they did that. So in this study, I think you can see the reference there at the bottom. You can read the study if you want, but I'll give you a brief synopsis. Basically, they built this really fancy model that was able to tease out the structured text and the unstructured text. So they used the structured text first if it was available in a structured form, and then in the case they didn't, they built this logic rule matcher that collected that then processed the information and was able to do it quite accurately, which is the exciting part. One of the problems when you do NLP work is that sometimes you find that because physicians write in such non-standard ways, it becomes hard. And I'll show you some of those slides. So this is the graphic of basically what they did. They had the structured entries, the unstructured entries, and they were able to sort of process them and then assign categories to them further on. This is an even more complicated model that describes how their tokenization and how the actual processing worked. Much of this is very much computer science and not the work that I do. I use the aggregate information, and sometimes I'm the one that puts the information in. And so I love these kind of slides, but I'm not an expert in the actual processing piece. That's where I turn to my computer science experts. But some of you may find these models interesting, and so I threw it in there. But the really interesting component was the deep learning model, where they actually were able to build to sort of gather even more information from the words. There we go. And so this is how they categorized it. I won't go too deep into the numbers, but they had, fairly robust numbers. And then this slide I think is interesting. If you look, this is showing the performance of their logic-based rule matcher. So it does very well, right? It's very accurate. But this is in the more or less clean data that was coming out of a sort of standardized record. So if you collect, this is the whole garbage in, garbage out. If you collect the information in a semi-structured, standardized way in some kind of form, their algorithm was really good, really accurate, north of 98% at worst, and most of them were 100%. So the rule matcher worked great when everything was in a nice form. It breaks down a little bit when you go to that second level and you need the natural language processing. And so you can see it's very good overall for many things. But some of the accuracy, the performance starts to drop into the 90s and 80s and 60s and 30s, and depending on the type, whether it was tobacco or something else. And so just to show you those stages where, based on the quality of the data, the performance of the processing can really change. This is another recent study that actually looked at social determinants and was a review of all of the different types of current natural language processing. I'm not going to tell you a terrible amount about this study because I want to tell you a little bit more about the current state. But just to sort of point out that there's lots of work going on in this area because in part, as we've talked about already, social determinants are so important for the health outcomes and health experience and just the health of the population that, there's lots of interest in trying to actually get these garnered in a better way. Because by the time, CaiHi and Infoway and all the vendors get all their work done, we're going to have lost another decade of meaningful collection. And so we're going to still have to be using the sort of garbage and try to clean it to a point that it's usable, even when all of the wonderful standards are embedded in the EMRs, which of course the vendors will drag their feet and not install it in anytime soon. So here's the current state. For the most part, in clinical research in Canada and in other parts of the world, we use surrogate measures. So we use indices of social determinants to determine where patients sit in terms of how they're measured. So this is just 3 examples of studies I've been involved in recently, where we looked at the outcome and then we evaluated that outcome. The modeling that we did, the regression modeling that we did, we compared that outcome with social determinants. So this was a study around pediatric hypertension and screening for blood pressure in children in Canada. So it's important to screen for blood pressure in both children and adults. And we detected a pretty, actually, I think, respectable rate of children getting their blood pressure checked. I have to admit, as a family doc, I don't actually check children's blood pressure that often, but after having participated in the study, I've now been much better at collecting blood pressures in children. I'm pretty good at collecting blood pressures in adults. But the rate of pediatric blood pressure is, in the sort of, in the sort of 2 or 3%. I'm not sure if it's in this slide. That may be from another study. It's like 1 to 3%, depending on the neighborhood and the community and the province you're in. But that's, that's as common. 1 to 3% is as common as lots of things we care about in family medicine, right? That's more common than Parkinson's disease and epilepsy and things that, we often look after. So this is a really interesting slide, in part because it bucks the usual trend. So if you look at the most, if you look at the most deprived the quintile 1 versus the least deprived, sorry, the most deprived quintile 5 versus the least deprived quintile 1, what you see is that the rate of high blood pressure, so on the right-hand column, is actually higher in income quintile 1. Now, the reason that probably is the case is because actually the screening is higher. So these are children in higher income families are getting more screening, and when you screen more, you detect more disease. But this is a fascinating finding, and there's all sorts of reasons why kids in lower income quintiles actually get screened for high blood pressure less. But this is sort of the opposite of most other health outcomes, where those in the most deprived groups actually have the highest burden of disease. In this case, the highest burden of disease was actually in the higher income, but it was a small number overall, and in part it was influenced by the higher rate of screening. So what do we mean? So let me pause here for a second. What do we mean when we talk about material and social deprivation? Or, we're using these indexes. And so these indexes are composites of different forms of deprivation or socioeconomic status that StatsCan has developed. So there are social deprivation indices and there are material deprivation indices. And they reflect different things. You can see the list there for social deprivation is all based on census data. So in the neighborhood that you live, what's the proportion of people who are divorced and live alone and have moved in the last 5 years? So residential mobility is an interesting surrogate for sort of the sort of niceness of the neighborhood, so to speak. That's probably a poor term, but material deprivation is more about the financial type things, right? The average household income, unemployment rate, high school education. And these are really commonly used indices to understand social determinants, which are composites of, income and some of the social things. And so in this study, this was also the pediatric blood pressure study. We showed that actually the material deprivation was the most important. And in fact, so in many of these indices, socioeconomic status, income tends to be the one that pulls many other things. So if you look at a combined deprivation score, it's not impactful. But when you pull out just the material, that tends to sort of pull out. So that's a effect that's seen in many studies. This is the skew for adult chronic kidney disease. So having high blood pressure puts you at risk for chronic kidney disease. But the thing that actually puts you at risk for chronic kidney disease the most, in part because it leads to the other risk factors, is your deprivation, your social and material deprivation. They actually flow together. So you can see the rates of, this is sort of a color coded kind of slide, but the more deprived, the lower socioeconomic status, the more CKD. What I like to say to my nephrology colleagues is that we treat a lot of poverty with dialysis, and it's not a terribly cost-effective or a good strategy, but year over year, these bands have barely moved. And so we're measuring it. We're not actually impacting it in a great way. And that's the challenge of equity, right? We can measure these things and say, these are inequitable outcomes. But to actually intervene tends to be really challenging. And we've yet to crack this nut. Those lines more or less look the same, and they'll probably spread out a little bit after the pandemic. We've not been great at changing this. PTSD is another thing that I've done a little bit of work in, and we see almost the identical pattern as CKD, where social and material deprivation affect the prevalence of this condition. And we've shown this in a cohort. We did some work where we actually showed this in Canada in CIPSIN, in that practice-based research and learning network. So we looked at just under 700,000 patients, and you can see the same pattern as in CKD. In fact, even more dramatic, right? The rate of PTSD goes up the more deprived you are from the least deprived. It's pretty dramatic, right? So the least deprived has a rate of PTSD, the percentage of patients in our cohort, almost 40% of the patients in our cohort came from the most deprived neighborhoods. in this country. And it was a 2 to 3.5, 3.8 fold difference, depending on whether you looked at social or material. In this case, the material deprivation actually had a lower impact, whereas the social deprivation had a higher impact. And so this is the kind of work we do. In terms of how we can address it in the last little bit, so there's a whole bunch of efforts going on to try to address poverty. The one on the left is the poverty screening tool that some colleagues in Toronto came up with. The Get Your Benefits the Get Your Benefits package is something that we've sort of used in Manitoba recently. They didn't like the idea of calling it a poverty tool, so we call it the Get Your Benefits. And there's really good data from Manitoba and other places that simply providing income or income supports to people make them healthier. And I can explain that later if you aren't familiar with the example. But probably the single greatest health intervention we could do would be to have universal basic income, and that's been proven in multiple jurisdictions. But we're going to pump money into nephrologists. So there's lots of work going on, and I think the next speaker is going to talk to you a little bit about sort of some of the conceptual implementation guides, and you sort of had some that was alluded to previously with the CIHI folks. And so getting this data collected properly and well, and not having to do all of this processing and cleaning, will be hugely impactful for the measurement side, and help us in that sort of learning health system model to maybe test out additional interventions as to what actually could mitigate these disparities between different socioeconomic and material deprivation type groups. I should point out some of the work that happened during the pandemic. My colleague Andrew Pinto, who's a family doc in Toronto, leads something called the Upstream Lab, and they put out a guide early in the pandemic, and they've been doing a study called Spark, which I think I have a slide for in the last minute. And they put out some early recommendations that we should collect the data. The folks in Ontario where he lives dragged their feet, but we actually took this up. And in Manitoba, these data were actually collected both for vaccination and for COVID positivity status, and actually impacted how the vaccination rollout went out. And we had probably one of the most equitable vaccine rollouts, thanks to my colleague Joss Reimer, who did a phenomenal job of actually, they really did take that into account. And so we had the highest vaccination rates in the parts of the province that were the most affected by COVID, or that had the highest existing inequities. So this is the work of Andrew Pinto in a project called Spark, which is about trying to collect socioeconomic, social determinants of health, racial, ethnicity type data. And they've done a whole bunch of work with patients to try to make sure that the questions that we ask are acceptable and valid. And they've done it with tablets and different things, and email surveys and things like that. So this was the study that we did with tablets, where we actually had the tablets in the waiting room, and the patients entered some of that social determinant data that they wouldn't otherwise speak to their physician about, or sometimes they do and sometimes they don't. This was a way of routinely collecting it. Much of what I would like to see is contained in the Pan-Canadian Health Data Strategy, which, if you haven't read it as part of your master's, I would recommend you all read, because it's important, and it should be the work that we're all doing if we're in this informatics world. And building this idea of a learning health system is really, I think, where we should be going, and moving our policies and procedures from sort of analog states, which they are currently in, and we think of health data as sitting in basements and in paper, to a digital construct where the laws and the policies and the use of it is really modernized, is, I think, the work of probably the next decade or two, and probably the work that many of you will participate in. So good luck. I'm looking forward to you getting it all done so that I can use it in my clinical practice and my research work. And just to sort of conclude that I think, I hope I've hit it home that these are important things, and that practice-based research and learning networks can contribute to this idea of learning health systems, and hopefully all of you will too. Thank you for your time and for listening. I'm 1 minute over. I apologize, but I hope it's still a bit of, if Linda will allow, we'll go a few minutes over if there's any questions.